All right, so emergency, terrorism, and disaster. Oh, actually, it's just disaster nursing and emergency because I took terrorism out. So the first thing we're going to talk about is the ESI, so the emergency nursing triage. So this is basically like rapidly assessing your patient to see where they fall on this scale of 1 to 5. So I always think 1 to 5, 5 would be the extreme, right? This one's opposite, and I always have to think to myself, this is the one that's turned around. To me, that's the way it works. So 1 is going to be your unstable vitals, threats to life, high resources. So like your trauma patient that comes in would be a 1. And if you look at this little scale here, it tells you, do they require immediate life-saving intervention? Yes, they're a 1. No. So then you would go down, you would read the next one. Are they high risk? Are they confused or disoriented? So is there any sort of altered mental status? Are they in severe pain or distress? If it's a no, then we're going to go down into the 3, 4, 5. If it's a yes, that makes them a 2. Level 3, they're pretty stable. They're not disoriented. We're not doing CPR, but they still are in that danger zone. So you see the vital signs down there. They need medium to high resources. 4 would be your patient that comes in and maybe we need to get a chest x-ray. So that would be like 1 resource, right? 5 would be like your DOT guy walking in just needing his yearly physical. So he just needs someone to sign off his paperwork for work. He'd be 5. He'd be your no resources, no threats to vital function, exam only, it's in good health. It's table 68-2 in your book. And the only way to practice this is to basically find, I believe that online, and I can try and find some later, some questions, I'll put them in the course for you. I think there's a website that you can go to, though, where it just keeps giving you patients, like it'll give you 5 patients, and you'll say, well, this is the one I'm going to see first. And I'll say, all right, now these patients are gone, we're going to add these patients, now who are you going to see first? And so it's just practicing, kind of like math. When we talk about your primary survey, does everybody have the 10th edition book? Does anybody have the 9th edition book, I should ask? Okay, so this has changed since the 9th edition. So go with my lecture on this if you have the 9th edition book. So now the primary survey goes A through G. Yeah, so pretty much everything has ended up in the primary survey. So basically your primary survey, you are going into a situation and you're just assessing this patient. You're going to first look to make sure that they have an airway, right? You're going to do a jaw thrust stabilization if you need to, but otherwise we are not intervening immediately unless we find something life-threatening. So we're going in, we're looking, do they have an airway? Yes. Are they breathing? So we're looking at their respirations. Do they have chest wall movement? C, we're looking at central pulses. And I should look back at the book because I think this has changed also, some of the labels.
This is circulation.
Yeah, circulation. So you're looking for circulation, making sure they have pulses. D, disability. So at this point, you're looking for LOC, doing a quick Glasgow Coma Scale. Assessing their pupils. E, so we're checking the environment. making sure that the environment is safe for the patient and you, making sure that the patient doesn't have any impaled objects, bleeding, bullet holes, etc. F has changed, so now it's facilitate adjuncts and family. So this is where we're going to get a full set of vital signs, including your heart rate, your respiratory rate, O2 sats. We're going to make sure that the family, if there's family available, are there to answer questions or, try and get a hold of the family. And then G is get the resuscitation adjuncts. So this is where you're going to get your labs, your EKG, NG tube, ventilation assessment, and pain assessment. And in your book, you just say LMNOP for those. Page 1632. Again, if there is a life-threatening condition found in any of those steps, you're going to do your interventions for that life-threatening condition before you move on. The only thing in the secondary survey now is your history or your head to toe. So this is where we're going back now, and instead of just looking them over real quick, we're going to do a thorough head to toe on them. If you guys need a brain jog of what a head to toe looks like, it's on 1623. And the I is inspect posterior. So make sure with these guys, because remember this is an emergency triage trauma. So we're log rolling them until they have ruled out any sort of spinal issues. So it looks a little different than your book, right? Yeah. I will not go back over and through the exact head to toe. You guys can read through all that stuff. Any questions about the primary and secondary survey? If you just follow the A, B, C, D, E, F, G, right? It goes to G now, and then HI. When we talk about emergency and mass casualty preparedness, what's the difference?
One of them is a rapid, all your patients is casualties, so you're going to be triaging and you're only going to be treating the ones that you can treat. The ones that are dying, you can't prevent it, you have to let them go.
That's your mass casualty. Yeah.
I was just going to say the number of people you're going to see at once.
Right, so the emergency is generally under 100 people, right? It's like the roundabout. And usually it's, this would be if you're on the Howard Franklin Bridge and you have a 12-car pileup, right, and there's all sorts of people involved, but we can still handle it with whatever county, emergency services that we have there. And I think I used a bad example because Howard Franklin, doesn't that combine the two counties?
Yeah, but Hillsborough don't show up and do nothing.
Oh, okay. So an emergency, we can handle it ourselves within our community. We don't need to call FEMA or Red Cross, right? And generally, like I said, it's under 100 people. A mass casualty is going to be greater than 100 people. This could be like Hurricane Katrina, right? Pulling in from all over the United States. Disaster workers, FEMA, Red Cross, Coast Guard, everybody we could. So that would be your mass casualty. So it can be man-made, like mass casualty, man-made or nature. Going to have permanent changes on the community. So like Katrina, those people are still, some of them, trying to rebuild houses and communities, and it just changed the entire feel of the community up there, right?
Everything but the strip. Everything but the main strip.
Yeah. What's the National Disaster Medical System? None of you guys, even with your LPNs, have gotten the emails. Would you want to be part of the disaster team? Yeah. And then they ask you, like, are you ready to go on a moment's notice? Will your job let you just leave? You're like, who actually has that job? Although, when I started school, it was right after Katrina, and one of my instructors was a nurse practitioner up in Massachusetts, and she flew down for 2 weeks down there, and she had crazy stories. And but the school they let her go. The hospital, she worked at the hospital and the school, and they both let her go down there for the couple weeks, and her husband took care of the kids, and she said they basically didn't sleep, so it's not like a glamorous job. I have another friend who, during Hurricane Michael, the one that hit the Panhandle just a few months ago, she went up for like 2 weeks, and basically like they had her in a hotel room eventually, but at first they were all just in a room on cots, and like nobody slept, and it was just a horrible situation, but they get paid well. So they organize volunteers, disaster medical teams. They basically have people that are ready to deploy within 8 hours. And they treat like 250 or greater patients a day, so they keep them going.
A lot of times outside too.
What's that?
A lot of times outside in tents.
Oh yeah, a lot of times you're outside in tents. What about the Strategic National Stockpile? You guys know what that is? So it's just what it sounds like. It's a stockpile of medical supplies and antibiotics and medications, just in case there is some sort of Katrina or something, so that they can get medications and medical supplies to the area. I don't remember how many hours they have to get it there, but basically it's strategically stockpiled throughout the country so that they can get it to the different areas that would need it pretty quickly. So basically there are these warehouses that have just stockpiles of antibiotics and stuff. So what do you think they do once those antibiotics start expiring or get close to expiration?
Send them to another place.
So they could, like they would send them down to one of the islands if they had problems down there. The military will take them because they've done lots of studies, and just because that expiration date is on that bottle, it basically means it's a year from the time it was bottled. But those medications are good for several years, so a lot of times they'll send them and they'll use them for military personnel. I know, you guys get the best of the best. So when you have a patient that comes to you and says, I'm really scared, this whole anthrax thing, so I'll tell you what I've been doing is I go to these different doctors and I get them to give me antibiotics and I keep them. So I have all sorts of antibiotics just in case anything happens. That way if anything happens, I can just take my antibiotics. What are you going to say to that person? What? Stop. Well, why don't we want them just taking any random antibiotic, first of all? Superbugs, yeah, it's not going to treat what they have. So we obviously don't want them treating themselves with just, whatever antibiotics they have expired in their cabinets, right? Even though we know those still work. So we would just make sure that they knew, like, don't do that. There's things in place that nobody would probably be without what they would need. We don't want you stockpiling your own antibiotics, right? So this is what she was talking about out there in tents. So if we have emergency and mass casualty incidents, sometimes you just have tents, and we have triage tents, and those nurses are basically just there to, obviously if the patients are walking in, they're not going to be blue or black tags. But if you're in a situation where like Twin Towers, right? So people get to the site, and now they have to go around and they have to find the survivors and non-survivors. And basically they have these tags. Is there a picture in your book? There used to be in the old edition, I think. But you can always just Google it if you really want to see what it looks like. Someone brought one in for me one semester. It's just a tag, and they have rip-offs, and so you would rip off whatever portion it is, and you would clip it or tie it to your patient. And so the green tags are going to be, just walkie-talkie. They're fine. Maybe they need a Band-Aid. Yellow could be that maybe they have a fracture, so they're going to need treatment. Red, these guys are not in a good way, so maybe they have a fracture and it's arterial, so they're a little more serious. So this was interesting to me, and I brought it up to Ms. Hoffrichter when I told her that I taught this stuff, and I said, they added a tag because this was her thing that she did. She went to this huge training. The counties and states and federal grants cover it, I guess. You can volunteer to go to this training for your area, and they take you up to New Orleans, and it's like a 3-day training where all day you're like doing like scenarios and you're learning all this stuff. And she told me that every county has a backpack that only the chief knows where it is or something, or there's like 2 people in the county. It's the mayor and somebody from the fire department knows where it is, and that's where all the anthrax supplies are. So I was telling her that now there's this blue tag, and she said, "What do you mean there's a blue tag?" I'm like, "It used to just be black. Remember, black would be anybody who's dead or dying. Like even if you're breathing and you're looking at me and there's bubbles coming out of your mouth and I'm tagging you black, that's because I don't expect you to live, right? But now it's blue if you don't expect them to live, and black if they're dead." So they added a color in there. So those of you guys who have had the training on the EMTs and medics, you guys have had the training back when. They added the blue. Huh?
They're not implementing them.
They're not? Oh.
I mean,
I don't know.
All our bags, we all got them on rescues in our engine, and they have the belts for the BLS.
Yeah.
And for the ALS, they actually have this big bag, and they just rip them out. So
yeah.
We don't have really yet. We're waiting on our grant money.
So as far on your grant money. So as far as your role as a nurse, remember, you need to be aware of your organization's emergency response plan. Make sure that when they have those annual in-services for you, that you're not just like standing there playing on your phone, that you're actually listening, because you don't want to be that guy when it does come in and you're like, shit, I don't remember what I need to do. And make sure that you're participating in any of the drills. So I actually got an email asking me if we would want to participate in the drill that's coming up at Bayfront, but she didn't give me a date or anything. And usually it's during the day, and I wouldn't be able to take you guys out of an entire clinical afternoon because it would only be like 3 or 4 hours in the morning. So if anybody is interested in that, though, I can text her back and find out exactly what date it is. Might be something cool to do, though. All right, so that's the down and dirty of trauma and triage. That's that one. See if I can get this to flip on over here. I'm going to put it up on here because I know it's not a required book, so most of you guys probably don't have it. All right, so let's go through some of these questions just to kind of make you think a little bit about them. Like, what's that?
What book is it?
It's the charity prioritization delegation. So a client comes into triage: fever, myalgia, headache, abdominal pain, vomiting, diarrhea, unexplained bruising that started after returning from Africa. The triage nurse suspects but is unsure that the client may have Ebola. What should the nurse do first?
That's me personally.